Ian, you can start.
Thank you. Good evening, everybody, and welcome to our webinar series. I'm absolutely delighted that we can introduce Dr. Charles Goodacre, Charlie, this evening. So welcome to Charlie, and welcome to those who may be joining us from the US. So good morning to Charles and those of you who might be joining from the other side of the pond. Just as a way of introduction, Dr. Goodacre received his DDS degree from Loma Linda University and an MSD degree in prosthodontics and dental materials from Indiana University. He served as chair of prosthodontics at Indiana University and dean of the Loma Linda University School of Dentistry. He is a diplomat and past president of the American Board of Prosthodontics, past president of the American College of Prosthodontists, and past president of the Academy of Prosthodontists. He has written lots of publications, lots of textbooks, over 200 publications actually, and he currently holds the title of Distinguished Professor of Prosthodontics at Loma Linda University. Charlie and I have actually met a few times in London, and also during the pandemic. We've met on various Teams and Zoom meetings where we have discussions about prosthodontics. He always inspires me. I always learn at least 5 things from our very short meetings. So I'm absolutely delighted that he's here with us this evening, and I'm also delighted that all of you who have registered have got the opportunity to listen to Charlie's thoughts when he is speaking this evening about which type of ceramic crown is best. He's going to discuss the pros and cons of zirconia and lithium disilicate. As the lecture progresses, you're able to write any questions that you may have in the questions box. And then at the end of the presentation, there'll be a short period of time where we will be able to answer some of those questions. We won't be able to answer all of your questions, and so those that we are unable to answer, we may be able to get back to you at a later stage. So it's my very great pleasure to hand over to Charlie to give his presentation. So thank you very much.
Thank you very much. I appreciate the opportunity to share my clinical experiences, because that's really what this is sharing what I've learned over a number of years of practice, which type of material suits which particular clinical situation. And first, I want to clarify some terminology and then just propose some guidelines before we actually get into the discussion. Relative to terminology, of course, the name zirconia means it's a zirconia crown with different structures and different degrees of translucency available today. But the name used for lithium disilicate crowns, some people say EMAX, and they think that that's lithium disilicate only. But the fact is there's different types of lithium disilicate that can be pressed or milled, the CAD system. And there's also EMAX zirconia that's available. So really we have to specify zirconia lithium disilicate, since EMAX is a trade name from Ivoclar Vivadent. Just a small point to eliminate any confusion. Now, the opinion-based aesthetic guidelines that I'd like to discuss with you that applies to both lithium disilicate and zirconia is, it's my personal opinion that a coping of either one of those materials with a master technician applying an aesthetic ceramic veneer produces the best aesthetic result. And monolithic crowns can produce an appropriate aesthetic result if you're restoring all of the teeth. And they also can produce an appropriate result with posterior crowns, but they really don't produce an exceptional result with single crowns in aesthetically critical locations, such as the maxillary anterior crowns. And I'll be showing a lot of those during the presentation, because that's what I find to be the most challenging thing that I do aesthetically, is individual anterior teeth. The ability of single monolithic crowns to match adjacent teeth, the lighter the adjacent tooth, the easier it is to match with a monolithic crown, the higher the value, such as making this not very elegant central incisor crown, replacing it with another one because the other central incisor crown was very light. In fact, doesn't match the rest of the teeth. but it's much easier to use a monolithic crown in that circumstance. But the more translucent a tooth is, the more difficult it is to match the translucent tooth with a monolithic crown, such as that first molar, where you can see the horizontal crack occurring in the clinical crown. The more intensely pigmented the teeth, the more difficult it is to have an ideal match with a monolithic crown, even with the layered materials that are much improved today compared to the original ones. And again, you can see the original second molar crown before they had any layering, and then the layered crown with a lot of coloring, and it's just more difficult the more intensely pigmented it is. Now I'd like to mention a little bit about optimizing the aesthetics of both types of crowns is best accomplished by sending 3 sets of digital images to your master dental technician. And so to me, you need to send pre-treatment digital images such as these 4 incisors that were going to be restored because they're small and tapered and worn. And then you send an image of the closest available shade tab from the particular shade guide that you prefer to use, and hopefully it's one where the laboratory has a matching porcelain to that. And then send an image of the closest dentin color after the initial tooth reduction. As you can see here, the tooth needs to be moist. In fact, leave a little layer of moisture on there so you see the real color of it, and then picking the dentin shade based on a guide such as you see here with this IPS natural dye material. So the technician knows the parent color of the dentin so that they can then form a core or foundation that will most closely match the natural tooth. And then selecting that dentin shade is particularly important with intensely pigmented teeth, because we're going to talk about which material matches best when you have a discolored tooth, an extremely dark tooth, ones where there's color variation. So that's very important to do, because you'll come across a lot of teeth. You take old restorations off, as I did here, and a lot of work needs to be done on the teeth, and you have variations in color and differentials that if that information is purveyed to the technician, then they can develop a series of crowns, as you can see in this picture, that are closely matched to each other, even though there's variations in the color background. Now let's turn our attention to determining whether to use a zirconia crown or a lithium disilica crown. And to me, there's 3 important decisions that I look to make in order to determine that decision. So what are those 3 decisions? And decision number 1, is the tooth primarily translucent, or does it have a definite zone of dentin coloration? So what do I mean by that? Well, let's take a look at this example. Here's a tooth that I would say has a definite zone of cervical coloration and an area of incisal translucency. So if you look at that, there's a definite zone of cervical dentin coloration, and then there's an area of incisal translucency. And that's as opposed to the other types of teeth that I call ones that are primarily translucent. You look at them and you have a hard time picking out the actual dentin color, except perhaps maybe in the very cervical aspect. And so that affects the material, in my opinion. So let's take a look at that. If you have teeth with a definite zone of dentin coloration, which type of crown should be used? Well, the truth of the matter is you can use both types of crowns if you have a definite zone of dentin coloration. So I want to share some examples where both types of materials have been used. But sufficient tooth reduction is, in my opinion, more critical with zirconia, because zirconia, even with the newer materials, isn't quite as translucent as is lithium disilicate. And so you have to have enough of the zirconia, enough tooth reduction that you can make a zirconia core and have a sufficient ceramic layer that masks the zirconia material. So let's look at clinical examples of using zirconia copings with an aesthetic ceramic veneer when you have a definite zone of dentin coloration. So in this particular example, where this person has worn significantly the incisal edges and the lingual surfaces of the teeth, requiring restorations, and we have a definite zone of dentin color with an enamel translucency zone. So again, those teeth were prepared, CAD/CAM milled zirconia copings were made, and then with the master technician doing their layered buildup with dentin, enamel, and then translucent layer, and then shaping it, glazing, polishing, and coming up with the definitive crowns that then were able to restore the teeth with a definite zone of dentin coloration comparable to the natural teeth with some incisal translucency. And then looking at what I consider to be the most challenging thing is a single anterior tooth. And this obviously has an older metal ceramic crown that doesn't have the proper shape or color. So then removing that, reshaping the tooth, making a zirconia coping with a ceramic veneer allowed for a better color match. And of course, the gingival zenith isn't quite exactly ideal compared to the adjacent tooth, but again, much improved. So that tooth had a definite zone of dentin coloration, and it worked well with the zirconia crown. And here's an example of a zirconia implant abutment and a zirconia veneered crown also on the tooth. And again, able to produce an acceptable result with the combination of the zirconia abutment and the crown itself with a zirconia coping and a veneer of ceramic material on the exterior surface. Now, this person had traumatic loss of a tooth. It was out in facial version, and the natural tooth actually was overlapping the lateral incisor. So again, this is an implant situation where a zirconia coping with a facial ceramic veneer was cemented to a titanium base to make a screw-retained implant crown that fit up into the gingivals, into the mucosa, and was able to obtain an appropriate result. Again, based on a master technician using the pictures that were provided. So we can do an acceptable result when we have a definite zone of dentin coloration with a ceramic restoration. Now let's look at lithium disilicate copings where we have a definite zone of dentin coloration. Such as this tooth was a traumatic injury, and appropriately so, the fragment was rebonded to the tooth for this younger person, and it lasted for a number of years, but then started coming loose fairly regularly. And so the patient was tired of that and wanted a more definitive restoration. So the fragment that had come loose, then the tooth was reshaped, and I've put a couple of little depressions in the proximal surface to give resistance to facial dislodgement of the restoration, kind of retention and resistance form depressions to help since the tooth preparation was relatively short. And then we're able to make a restoration with a definite zone of dentin coloration, an area of translucency with some opacity in the incisal third, again, all made with lithium disilicate. Another example where there was substantial facial wear, incisal wear, and chipping, and lingual wear that required restoration of the 4 anterior teeth. So those teeth were prepared for the lithium disilicate copings with an aesthetic veneer. And then the restorations were actually shortened a little bit to create better proportions for the teeth. And you can see on the radiographs, that's one of the interesting things of lithium disilicate. It's translucent, sort of like tooth structure. So you just see the cement line over the prepared tooth. And that works well when you have intact teeth. It can be a little confusing in my mind when you have extensively restored teeth, like posterior teeth, and you put a lithium disilicate crown on it, you can see through, and you see all these interesting materials and shapes underneath that are a little more confusing than the zirconia that blocks it all out. But anyway, this was able to obtain the result with a definite zone of dentin coloration and incisal translucency with lithium disilicate. This being an example of a zirconia abutment for a single crown, and then a facially veneered lithium disilicate coping over top of the ceramic veneer that was then cemented in place to produce the definitive restoration. And of course, the space is a little large mesiodistally, but again, it can satisfy the needs of a definite zone with incisal translucency. So to summarize, both zirconia and lithium disilicate can be used when you have a definite zone of dentin coloration. But to me, the preparation depth is more critical when you have a zirconia restoration. Now, what about teeth that are primarily translucent? The other part of our question number one. And so to me, high translucency lithium disilicate works best when you have translucent teeth and they have normal dentin color. So you see an example of this opaque central incisor crown that just wasn't blending in with what I call the translucent teeth that are all the rest of them, where you have a hard time picking up the dentin coloration except for the areas where there's gingival recession exposing the root surface. So making a high translucency, the HT lithium disilicate crown, produced a more aesthetic result for us because it has that translucency that allows the color of the tooth underneath to project through it and works better to me with this type of a natural tooth. Another example, traumatic injury to the central incisor, a lot of tooth structure missing. So that tooth was prepared for a high translucency coping of lithium disilicate, again with the aesthetic veneer on the external surface, as we can see there. And then that blends in nicely for this translucent type of tooth. And then looking at it in the black and white picture so we can determine the value match. And here a high translucency crown was used to replace this opaque and over contoured metal ceramic crown that was creating some gingival irritation. So that crown was removed and the tooth preparation refined so that we could make a lithium disilicate crown, high translucency, that then blended in a little better. Certainly not perfect, it's a little high in value, but better than what we had, and we're able to improve the gingival response by making a properly contoured submucosal tooth or crown form. So there that crown is after 6 years and 9 years. And of course, the match becomes poorer with time because the natural teeth increase their pigmentation, the crown doesn't. So almost all crowns that were pretty good looking to begin with, after enough number of years, they no longer have an ideal match. And this traumatic injury resulted in loss of the lateral incisor that required some bone grafting in order to allow for implant placement. And of course, there was damage to the central incisor that required a restoration. So here, just as an example, we happen to use a metal abutment, that is, used metal ceramic alloy cast around a prefabricated company generated abutment. And then that was veneered with porcelain, and then to create the cervical aspect of the abutment. And then a translucent lithium disilicate crown was then cemented over top of that abutment. And that allowed for a reasonable blend, although it's a little opaque in the cervical aspect, again, because of the background color being different in the metal ceramic abutment. So to summarize, high translucency lithium disilicate is the preferred material when you have translucent teeth that have normal dentin color. That gives the very best result. Now, decision number 2, is the prepared tooth moderately or substantially discolored? So what can we do with both of those options? So for prepared teeth that have moderate discoloration, let's talk about which crown we would use. And again, to me, you can use both of those materials, but you can't use high translucency lithium disilicate, as the crown will appear a little bit dark because the tooth discoloration will project itself through the high translucency material. That's an aesthetic advantage. When the dentin is normal color, the color of the tooth will come through the restoration, but not when it's slightly discolored. So let's look at some clinical examples of using zirconia copings with aesthetic ceramic veneer for teeth that will say moderate dentin discoloration. Well, what is moderate dentin discoloration? We'll just show some examples. But remember, it requires proper tooth preparation reduction to mask the tooth discoloration. and provide a sufficient layer of the more translucent veneer porcelain to mask the somewhat opaquer zirconia core and develop the desired shade. So again, a crown on the central incisor needed to be replaced for aesthetic reasons. So the crown was removed and the tooth preparation refined. And then for this particular situation, in order to try to learn, I've done a lot of this over the years to try to learn which material is best suited for a particular situation, because that prepared tooth has a lot of variations in color. We can even see the dark areas here where the pulp used to occupy. And then there's opacity inside of here because it's endodontically treated, and you can see some of the restorative material in there. So they look similar on the bench. When I looked at them, I said, wow, these all three ought to be very, very similar. But they look quite different in the mouth when you put some moisture underneath of it and you seat it over top of it. And you can see the high translucency. Lithium disilicate at the top turns darker than it should be. The medium translucency is better, but I chose the zirconia with the ceramic veneer because that did provide the most aesthetic result. Now, the truth of the matter, I didn't test low translucency, moderate opacity, the MO, or high opacity lithium disilicate, or some of the other types of zirconia materials that continue to be improved. But again, for me, I chose the ceramic veneer because it gave the best result. Replacement of, again, this dark central incisor crown. And I'm trying to show what I consider to be the most challenging thing, the individual anterior teeth, because I do see a lot of people, they show some very elegant, nicely done work, and it's all the teeth that are visible have been restored, and that's a much easier situation to deal with aesthetically than some of these. So for this situation, the crown was removed and the tooth preparation refined, and then a zirconia veneered crown made for that situation, again, produced a more aesthetic result, except for the tooth is a little bit wider than the other side. So we could have considered some bonding of the mesial surface of the adjacent natural tooth, I suppose, to reduce the width of it, but that was not done. And there's placement of that. There's 4 years post-placement, and there's 6 years post-placement on that particular restoration, and there has been some change in the interdental papilla over that period of years. Now let's look at some clinical examples of using medium translucency and low translucency lithium disilicate, because we don't want the high translucency. We want to give a little more block out, and the selection of the degree of translucency or lack thereof is based upon a clinical decision, looking at the tooth and the pictures, working with a master technician that then knows what material will be best suited for the situation. So here, medium translucency lithium disilicate crowns with facial ceramic veneers, they were used to replace the 2 premolar metal ceramic crowns. So they matched the more translucent teeth. As we can see, the natural teeth quite translucent except for the very cervical aspect. So the existing crowns were removed, the tooth preparations reshaped, and then the crowns made with a very light color. In other words, the ingot, the medium translucency, was a shade A1 with a facial veneer to mask out the color and the color variation between the 2 teeth. So again, that produced a more appropriate result in matching the rest of the tooth with the more opaque core and then a translucent layer of porcelain on the outside. Another example using medium translucency lithium disilicate, because again, the discoloration was, in this case, a little more substantial on one of the 2 teeth after the existing crowns were removed and the teeth shaped. So you can see the lateral incisor is actually quite pigmented in the very cervical aspect of the tooth compared to the central incisor. And then you look at the crowns, and the central incisor has a better match because, again, the amount of reduction that was possible on the lateral incisors quite modest, and therefore using in a very light medium translucency core that is higher in value. And then you put the veneer on the surface and you're seeing more of the coping material underneath that had high translucency, so it's a little bit light compared to the central incisor. And this very, well, we say moderately dark lateral incisor tooth that was endodontically treated was somehow much darker than the other central incisor that was also endodontically treated that we left alone. And so the tooth was prepared, and then the dentin shade being selected here, picking the closest from the shade guide to the cervical aspect of the natural tooth. And then again, low translucency in this case, Emax shade, the bleach 4, which is a very light core, a very white core to block out the darkness, and then having sufficient thickness to get close to a match with the central incisor, closer than what was present previously. And again, no single anterior teeth are rarely ever perfect. I don't claim to have arrived at that point. We just try to get as close as we possibly can. Another endodontically treated and very dark central incisor crown that needed to be changed. And so again, using a low translucency and the BL4, the very light lithium disilicate core material over top of that, and then having sufficient thickness to have some material over the top of it. So again, the tooth was prepared and the restoration in place that you can see there, along with refilling the canal because it wasn't restored completely in the initial endodontic treatment. So again, to summarize, to me, both zirconia and lithium disilicate, but again, not high translucency, those veneered crowns can be used with teeth that have moderate dentin discoloration. But again, the preparation depth is more critical when you have zirconia. So now, what about for prepared teeth that are substantially discolored? What type of crown is best? To me, a zirconia crown works best when you have a substantially discolored tooth. And what do I mean by a substantially discolored tooth? Well, let's look at some examples where zirconia copings with the aesthetic veneer were used for substantially discolored teeth. So this particular individual has some crowns on the anterior teeth, a lot of gingival discoloration, and so those were removed, some provisional restorations made, along with some curettage, trying to improve the gingival health, particularly with the patient's right central incisor where it had quite a bit of inflammation. So reducing the bulge there. And then in removing the crowns, that's what I encountered. And of course, I ground a little bit too far through the crown into the underlying tooth structure. So that had to be filled in. And then the final result was much improved with the zirconia crowns you can see in the radiograph, along with the change in the gingival health, although the gingival zenith, again, is a little bit different. That's very, very difficult when a crown has a poor gingival zenith relationship to the adjacent teeth, very difficult to have an ideal result. It can be improved a lot by the way the crown is contoured, and that's a whole nother topic unto itself. How do we encourage or get the mucosa and the gingiva around a natural tooth and mucosa around an implant to move incisively? There are ways that we can encourage that. But there's a very dark endodontically treated and restored maxillary first molar that was restored with a zirconia coping, milled coping, and then an aesthetic veneer on it that blended in better. It's a little white or light in the cervical aspect, and that again, that's related to the depth of reduction that you feel you can do. The more reduction thickness, then the more translucent layer of porcelain that you're going to be able to apply over top of the core. And the zirconia core has to be sufficiently thick to mask out the color. So it's a reduction depth situation. Here's another one where, again, extremely dark underneath of the existing metal ceramic crown. So that was removed, the tooth reshaped, and then the zirconia coping with the aesthetic veneer. And this came out a little bit closer in terms of matching the premolars anterior to the crown. If you'll notice here, there are substantially discolored, particularly the first molar has a green color. I don't know where that came from, but the maxillary first and second molars were restored with medium opacity lithium disilicate. And as I look back, I think high opacity would have been even better. The second premolar didn't have as much discoloration with it. So you can see there was a medium opacity lithium disilicate coping with a ceramic veneer, and there was a much better matching of that to the premolar in front of that crown, whereas the two in the back, they're a little bit darker than would be ideal. And so again, it probably would have been better to use a higher opacity material with the lithium disilicate on the molars, and that would have masked out the color perhaps a little better. So to summarize, zirconia crowns to me are well suited for use with substantially discolored teeth, but medium and high opacity lithium disilicate can also be used. So again, that'll work in both situations. Now, decision number 3, which type of crown should be used when there's limited tooth reduction? Because we encounter a lot of teeth where we simply can't reduce the tooth, or we choose to do a very conservative reduction, limited to primarily the enamel on the tooth. So we take an example. This was a traumatic injury, chipped off the incisal edges, and those were built up with a composite resin material. And then if you look at the lateral incisor with the existing gingival recession, that finish line is less than a half a millimeter deep, and that tooth would not tolerate any more reduction. But fortunately, the dentin is normal in color. So therefore, again, that's where high translucency lithium disilicate is ideal for such teeth where you have limited reduction, because the color of the tooth will come through and improve the result. Even though the lateral incisor is still a little bit lighter than the central incisor, it was better with a high translucency material than it would ever be, in my opinion, with a zirconia crown. So it's also ideal when minimal tooth preparations are used that terminate primarily in enamel. So let's look at some of these minimal tooth preparations, primarily in enamel, for normally colored teeth. This individual needed some orthodontic treatment. There was quite a bit of wear and, again, inflammation around the tissue. So obviously treatment number 1 would be some periodontal treatment to improve the gingival health in the area. So that was completed first, and then orthodontic intrusion was used to decrease the gingival visibility and align the gingival zenith, not paying attention to where the worn incisal edges were, and the lingual surfaces were also worn. And some people would look at that and say, well, you could do a veneer, and yes, you could, but the challenge is the lingual surface needed to be restored, and so I needed to control the occlusion. So I do what you might call a veneer crown, where it's very thin on the facial and proximal surfaces, but goes around the lingual surface. So it is a complete coverage. I don't know what other term to call it other than a veneer crown, that's then bonded to the tooth and will allow the occlusion to be corrected when it needs to be done. So again, those teeth were prepared with minimal preparations. And again, let me back up. It works best when you have square type of teeth where there's not much flare from the gingival interdental papilla to the incisal edge. A tooth that's very triangular in shape doesn't lend itself as well for these minimal preparations as ones that are basically square with relatively flat proximal surfaces. So the teeth were prepared, and then high translucency lithium disilicate crowns, again thin on all surfaces, but allowed for the restoration. And then those were bonded in place, and it provides an aesthetic result because the color of the teeth can come all the way through the restoration because of its thinness. So there was our pre-op smile, and there was the post-op smile. And ideally, we'd love to have gingiva down in between the teeth, but the spaces between the existing teeth don't always permit that to happen. Another example of orthodontic treatment prior to minimal tooth preparations that were terminated primarily in enamel. You can see the edge-to-edge anterior occlusal relationship with the central incisors turned in. And then after the orthodontic treatment, the teeth were moved into a proper relationship. And there was a lot of wear on the lingual surface, so those were moved so that we wouldn't have to do much reduction on the lingual surface. And again, doing minimal preparations on the facial, proximal, and lingual surfaces, making again these what you might call veneer type of crowns to control the occlusion as well as the facial surface. So there's the pre-treatment, the prepared teeth, and then the definitive crowns bonded in place, primarily to enamel. Although we can see, if you look at the prepared teeth, there's a little area of dentin exposed on both of the lateral incisors as we approach the gingival tissue. And just a third example, similar type of situation where the teeth needed to be realigned anteriorly due to the wear incisally and the tooth positioning. So again, during the orthodontic treatment, and there was a little diagnostic waxing done during the orthodontic treatment to establish a beginning point for the length of the teeth that would be suitable as for aesthetic reasons, as well as give some idea to the orthodontist where the final crowns might be located. So there's, after the completion of orthodontic treatment, some composite resin prototypes just to approximate the length and gain patient approval for that process. And then minimal preparations on the incisors, and actually there was no preparation of the canines at all. Could have done that, but we decided not to because they were totally convergent toward the incisal edge, so there were no undercuts on the canines at all. And you can see the extreme thinness of the veneers on the canines, again bonded to enamel. And there they are, crowns made on the working cast from the facial lingual view, where the occlusion needed to be modified lingually. And then after bonding the crowns in place, and then 2 months post-placement after the gingivas had a chance to respond positively to a smoother surface, then the final restorations. So to summarize, high translucency lithium disilicate is recommended for tooth preparations with minimal reduction depths and normally colored tooth structure. Now, for prepared teeth that are have substantially discolored dentin, but there's limited tooth reduction, which type of crown should be used? Well, there is no ideal material. And so I use this example, one of the strangest situations I had encountered, where the central incisors were quite light, and yet the endodontically treated lateral incisors were very, very dark and needed some restorations to improve the aesthetic result. So the teeth were prepared as much as could be given the amount of tooth structure available. And first thing, I thought zirconia crowns would be a good option. So had zirconia crowns made, and they didn't pass inspection. Obviously, they're a little blotchy and they're a little opaque, and it's very difficult when you don't have enough reduction to be able to have a zirconia core and then have any translucent type of porcelain over the surface. So then those were remade with low translucency lithium disilicate, and again, it made a better result, but not at all an ideal result. So for me, there is no good example, no material for a highly discolored tooth where we can only do limited amounts of reduction. Now it's time to summarize the overall findings from the above clinical examples and share my final opinions relative to the materials. So I would propose these guidelines based upon having done a lot of challenging restorations for a number of years. Copings of either zirconia or lithium disilicate with an external ceramic veneer are aesthetically superior to monolithic crowns. That's my opinion. And monolithic crowns, however, they can produce an appropriate result when you're restoring posterior teeth or when all of the visible teeth are being restored. But it's not an exceptional result with single crowns in aesthetically critical locations, even with the wonderfully layered monolithic zirconia blocks that they can mill crowns out of, and they can work okay posteriorly, but they're not the most elegant, in my opinion, on anterior teeth, particularly replacing a single maxillary anterior tooth. Optimizing the color of all ceramic crowns, both types, requires pre-treatment images, shade selection images, and Denton shade images that would go to the technician, as well as smile, so you technician can see the smile line, how much of the tooth is visible. All those factors are very important. And then the three important decisions that we reviewed in determining which type of material to use. Decision one, determine if the tooth is primarily translucent or does it have a definite zone of dentin coloration. And when teeth have a definite zone, then you can use both of the materials as long as there's adequate preparation depth when you use zirconia. If you have translucent teeth with normal dentin color, then use a high translucency lithium disilicate crown. Decision two, is the dentin moderately or substantially discolored? For teeth with moderate discoloration, both zirconia and either medium translucency or low translucency lithium disilicate can work, but not high translucency. And then zirconia crowns are well suited for teeth with substantial discoloration. But again, there needs to be adequate tooth reduction. And decision number three, what type of crown is best suited for teeth with limited tooth reduction? That's high translucency lithium disilicate for teeth with limited reduction that have normal tooth color, normal dentin color. And with limited tooth reduction and substantially discolored dentin, to me, there's no ideal material. It's extremely difficult to have anything that's going to be close to an ideal result, replacing particularly single individual teeth with natural teeth adjacent to those. So I thank you for your kind attention and hope you found this presentation to be beneficial. And I understand we have some time for questions, should there be some.
Thank you very much, Charlie. That was fantastic, and particularly those guidelines which highlight your thoughts regarding these types of restorations will be very helpful to us. I think Fatima is able to field the questions, and I understand that there have been some questions whilst you were speaking, so I'll hand over to Fatima, who will be able to ask them.
Okay, thank you. Okay, one of the questions that have come in is just saying, oh, thank you so much for an excellent lecture, Dr. Goodacre. Are there any specific cements, such as shade, etc., you would recommend in both zirconia and lithium disilicate materials when managing different translucency and shades of dentine?
Well, I use a resin cement, of course, for all those, for both types of restorations personally. And if you have a high translucency crown, let's say one of those with minimal preparations, then you want to use a totally translucent cement. And so I use a translucent cement for any of the crowns where there's normal tooth color and I'm putting a high translucency crown on top of it. And then you can pick the shades for the other restorations depending on what you do. When you try the restoration in, if it needs a little tiny bit more color, then you can put use a cement that has perhaps a slightly more intense shade than the restoration that you picked, and it has some minimal effect. But they're all, for me, they're all resin cements, and then I pick the translucency or the shade based upon the restoration and the tooth color.
Okay, thank you. We've had another one that's come in. When should you restore worn maxillary teeth with direct composite rather than ceramic?
Well, that's a question for which I don't have an ideal answer. You know, there are situations where people have milled off all of their teeth, and then you can do some composite resin builds up as a diagnostic procedure or to see how long they last. Sometimes they'll do quite well, but I don't find them to be the ideal aesthetic result in the long term. Like some of those examples I showed with those worn anterior teeth, if I had bonded some composite resin over those, it would look okay to begin with, but in time, it wouldn't have the elegance to me of a wonderfully glazed ceramic material. So I don't use that extensive when there's a lot of extensive wear, except as a diagnostic procedure. And then sometimes we see how long it'll last. And there are patients who cannot afford all the sophisticated ceramic restorations if they have a lot of posterior wear. So I meet the patients where they are, and sometimes that's the best choice.
Okay, thank you. We also have, which would be the preferred material for monolithic molar onlay restorations in full mouth tooth wear reconstruction cases?
Well, from my experience, you can use either material. You can, when you bond, and of course the bonding of etched lithium disilicate, because you can etch the internal surface. And I find if aesthetics is important when you're bonding a top surface of a posterior tooth, then the lithium disilicate will provide a better result if the tooth underneath is reasonably normal color. If it isn't, then zirconia can work quite well. And I know they're making improvements all the time, but the actual ability of a resin cement to bond as superbly to the inside surface of zirconia is not quite as effective as it is to lithium disilicate. So the stronger zirconia and the slightly weaker lithium disilicate, when they're both in the mouth, they seem to produce comparable performance. So I'm looking at what's going to be the most aesthetic restoration, if that's important. And I didn't put it in this presentation, but I have some inlays and onlays out of ceramic material comparing. Here's one with zirconia and here's one with lithium disilicate. And the lithium disilicate wins the aesthetic award, but that's sometimes not critical posteriorly.
Okay. I have a question on longevity of these porcelain restorations. How long do you normally tell your patients that they will last?
Well, I don't make any elegant promises to them because that's a little risky. I've made crowns for people and they've managed to destroy them in a reasonable short period of time, and then I have people that basically the restorations outlive the individual. So that's a hard thing to say. So I basically avoid that. I just tell them that the data is very favorable, and of course Ken Malamant in Boston has the most sophisticated long-term data on lithium disilicate restorations, and he's in fact shared with me a publication that's, I think, has already gone in now for publication with his most recent data, and it's very favorable for lithium disilicate as it is for zirconia too. When you make a monolithic zirconia crown, they'll break, but not very often.
Okay, thank you. We have, does Dr. Goodacre ever bleach the really dark crowns before restoring, or would he consider that is a waste of time?
Well, some of those extremely dark teeth, I remember years ago doing internal bleaching of them, particularly if they were endodontically treated or the external surface. It's kind of what I'd call a temporary effect, and so I would rather just work through the coloration process with the crown and not depend on the bleaching, because bleaching is not a long-term solution. So if you whiten a prepared tooth, make a crown to match it, and that whitening over time changes, then the color of the crown will change, if unless you totally block that out with a very opaque restorative material, crown material. And if you block it out totally, then you didn't need to whiten it. So that's, again, that's my opinion. Some people do whiten it. I do have patients whiten natural teeth before we do restorations, and I'll have them do the whitening and then wait for a period of time to have the tooth color stabilize. And then I let them know, you're in for if you want to have a perfect match between these whitened teeth and the crowns, you're into a lifetime of tooth whitening.
Okay, thank you. What protocols do you recommend for bonding to zirconia?
What protocols? Well,
Yeah.
pick one of the modern cements that the companies advertise based on zirconia, and follow their exact directions, because they're all slightly different. Ivoclar has some wonderful cements. 3M and SB has some wonderful cements. It's really just a matter of picking one of those and following the company recommended protocol.
Okay, thank you. Another question has just come in. Thank you for a wonderful presentation. I'd like to ask, in the situation where there is minimal remaining dentine and a severely discolored root treated tooth substrate, would you suggest first internal bleaching to help you in the final aesthetic result?
Well, again, you can do some of that, but again, the internal bleaching, as has been shown in the endodontic literature, the internal bleaching is not a permanent solution. But where I would do that is in place of a restoration altogether, where you would remove the access filling material, let's say on a maxillary anterior tooth, do your internal bleaching, see how long that lasts in order to avoid any type of a veneer or crown, and leave the tooth intact. Because an intact endodontically treated anterior tooth is stronger than anything we can do as far as preparing the tooth. That's going to weaken it. And of course, we can put a post and core in there. But again, the post itself weakens the tooth unless the final crown can grasp a substantial amount of tooth structure. So I would use the internal bleaching primarily to avoid a restoration and see if it can produce an adequate result for a given period of time.
Brilliant, thank you so much. Another question just come in. What protocols do you recommend for bonding to zirconia?
Well, again, that's following the manufacturer's recommendation for a cement. And I would just suggest, pick out an Ivoclar Vivadent cement, or pick out a 3M SB cement. Those are the two ones I'm most familiar with, and then follow the manufacturer's instructions precisely as to how they clean and treat the internal surface, the materials that they put on the internal surface before they apply the cement, and just follow their exact protocol, because that's the best you can do. And I still don't think the bond is as ideal to the inside of a zirconia crown as it is to an etched lithium disilicate crown.
Okay, you may have sort of touched on this before. Do you ever consider bleaching before crowns, i.e. tetracycline discolo?
And yeah, I do have natural teeth adjacent to where I'm working whitened, if the patient really wants to change the color of the rest of their teeth. But I personally discourage that, because once they do that, you bleach the teeth next to the restoration you're going to make. You do that, it gets a lot whiter, and then there's a back off process down to some stable level that takes at least 2 or 3 weeks afterwards to stabilize itself out. Then you make the restoration, you put it in, and then if they don't whiten their teeth periodically, the color matching is going to go back to, so the crown is going to be too white compared to the natural teeth. And then if they over bleach the teeth, the natural teeth are going to be whiter than the crown. So I would rather not have patients bleach their teeth, but some of them do, and they want to have whiter teeth. And I just tell them, well, you're into a lifetime of tooth whitening if you're going to want to keep it that way.
Sure, okay. How do you recommend finishing the restorations at the chair side if occlusal refinements are required?
Well, there's a whole series of companies that make very nice polishing kits. You know, Brasseler, Comet are the two I'm familiar with, and they make polishing instruments that work very well. And to me, both lithium disilicate and zirconia can be polished very, very nicely to a high sheen after doing occlusal adjustment.
Okay. This one might be an older one. Does Dr. Goodacre use ceramic in patients who are going to have ortho treatment, for example in young patients, or does he always wait to restore after ortho, given this isn't always possible?
Yeah, well, first of all, for youngsters, I try to avoid restoring the teeth as long as possible, because there's a adolescent position of the gingiva, and then that gradually changes as we get into adulthood. So I'd rather stay away from any restorations on younger individuals. That's where I would be doing my heroic bonding procedures, whatever it takes to delay the treatment as long as possible. Following kind of the same guidelines, you know, don't put an implant in a younger individual, because there is no perfect age at which you can put an implant in and not have changes occur, because facial growth is going to occur and it's going to change the relationships over time.
Okay, thank you very much. I think that's the end of our questions, actually. We've come to the end of our questions.
Thank you very much, Fatima. Can you hear me, actually?
Yeah, we can hear you.
Yes.
Perfect. Well, thank you, Charlie. That was as I expected it to be. Fantastic. You mentioned this paper that's recently been written by Ken Malmont, looking at longevity of restorations that you'd seen. Where will that be published? Because there will be people who want to read that, I think.
I'm assuming he's going to publish it in the Journal of Prosthetic Dentistry, and you can look up Malament, M-A-L-A-M-E-N-T. He has a whole series of articles that he's done in the past with different all ceramic crowns, and he has the most robust database. He follows all of the all ceramic restorations that he's made over the years, and so he has a huge database. And I've visited with him in his office. I've seen his technicians, and they do a very nice job with the restoration. So I believe his data is a good guideline. And I've forgotten now exactly, you know, he sent me a copy of the paper a few weeks ago that I read over, and it has a very low failure rate for lithium disilicate crowns. It's very favorable.
Yeah, that's okay. That's really helpful. Okay, well, on behalf of the Faculty of Dental Surgery, Charlie, thank you for delivering your lecture this evening. It's been very informative, and we've obviously generated quite a lot of discussion around it. We did discuss perhaps writing this up as one of our articles for our faculty dental journal, so those listening should keep their eyes open for that, which will be published subsequently. But it just remains really for me to say to everybody, thank you for joining this evening, and a huge thank you again to Charlie. And we look forward to perhaps hearing another webinar from you in the near future. So thank you once again, Charlie.
You're very welcome. Thank you, everyone. Have a wonderful evening, or wherever you are. Thank you.
Okay, thank you very much.